Hey guys, Kim here, and you are tuned back into Kim E, the Diabetes MP. So we are back for another one. And the new show that I have going on this YouTube channel is The Health of the Culture. Now, sidebar, if you hear voices in the background, that's my little one out there with my mother. They're two peas in the pod and they talk a lot. And they're both loud. So just in case you hear them, that's what that is. But welcome back. If you have not already, I have episode 1 of The Health of the Culture, where I really go over why I wanted to start this new show, this new series on my YouTube channel. Again, this will not only just go up on YouTube, but it'll also go up on LinkedIn. It'll also go up on my Facebook page as well. And then I'll take clips and put them up on Instagram and all that jazz, all that, razzle dazzle. So, but the first episode, I really took some time to explain why I wanted to have Health of the Culture. So on that note, guys, let's get right into our hot topic. So as I was sitting down and preparing for this episode, I was thinking about what's really kind of going on, and I was looking online and I saw some trending topics for 2023. Some of them little relevant. Some of them I feel like are not as relevant as, what people are saying they are. But then I really did some reflection of like, well, what are you hearing, Kim? Like, what's the talk of the town? What's the word on the curb? Okay. And one of the things that I can say for sure is something that if you're not aware of this, if you've not already gotten a taste of this, is value-based care. So I want to talk about value-based care versus fee-for-service care. And I'm going to share an article with you all, but just to give you a little background, traditionally, we as providers, if you've been a physician, if you're a physician, if you're a PA, if you're a nurse practitioner, typically we have been a part of a model called fee for service, meaning that you do a service and you get paid a fee. Okay, very simple. Somebody's coming in for this, I see them for this, and then I am able to bill for that particular service that I've given, fee for service. Okay. Well, over the past, I will honestly say, slowly but surely over the past decade, something called value-based care has become all the rage. And that is where the transition is. And what I really want to do is kind of talk about that, give my opinion about it, because one thing that I'm not sure if you all know, but for like 10 years almost, actually longer, because I'm a part of an organization that has a model of it as well. Probably, for well over a decade, I have worked at organizations that had a value-based model in place. Okay. Now you may be wondering, what is value-based care? What is this model, Kim? And you may have seen it, but did not know what it was. If you are not working in it, you may not have known what it was. You might have heard the term, but probably didn't know that it was an actual model of care that people are actually like doing at organizations. And there's a transition. And I'm going to be honest with you guys, the writings are on the wall. This is the transition. Now, of course, fee for service is never going to go away in some settings, and I have also seen, especially in the organization that I work in now, that I have seen a hybrid. I have seen where providers have done both. They have offered both. They have one side is fee for service because of whatever they're taking care of, but then also they have a whole other model that is simultaneously going as well. That's value-based care. And so all that to say is, you may have seen it as risk adjustment, risk management. You might have heard those terms. All of that plays into value-based care. So let me go ahead and let me see first. Let me make sure that I am sharing the right article first with you all. So let me get back to where I am, and I want to share this article with you all and encourage you all to also go and read up about it, because here in the next few years, your organization may very well adopt some form of it as well. I'll just give you my overall thoughts about value-based care, and what I have seen from different colleagues and coworkers that I have worked with. One of the things that I have found is that for some providers, it is very hard to wrap their minds around what value-based care is. And I'm just going to be very candid with you. It is a mind shift as a provider, because when we go to school, though we are told that we should give patient-centered care, the patient is in the center of the care, what we're really taught how to do, and this is for everyone, honestly, the patient comes in with an issue and we evaluate that issue. That's very fee for service. Whereas with value-based care, you are looking very much at the patient as a whole. You're looking at, their risk for chronic disease as a whole. And there is a whole scoring system, the patient's risk adjustment score, and there are certain diagnoses that have no score or have a small score. You're really looking at certain diagnoses that you need to capture and you need to address in order for it to count, basically. Now, most people, from what I found, in if any of you all are a little bit more well versed in this than I am, drop down in the comments, talk about, let's have this conversation. But in the environments that I have been in, the organizations that I have been with, they have been in a contract with CMS, Medicare, Medicaid. And Medicare and Medicaid, because this is really what they started, they are wanting us to capture certain diagnoses. These are heavy hitting diagnoses. These are the diagnoses that basically cost the healthcare system a lot of money. So what would that be? COPD, CHF, diabetes, hypertension, and there's a number of other ones, but these are your biggies that if someone has these diagnoses, that you should address them, you should capture them, you should address them. Somebody needs to address them within the year. Okay. And what I have found is that there are contracts, organizations that contract with CMS to be able to get reimbursement for addressing these diagnoses, these issues, these conditions. And what I find is, if you are a person, like most nurse practitioners are, like most physicians are, you're used to going in and managing the whole care. In this instance, there are some things that you yourself are not going to manage. And what is considered managing it is not necessarily treating it. And so I know it sounds confusing, but what I have found with a lot of my coworkers is that they're still in the mindset of being the PCP. And just simply put, the volume that we have to get, you can't do that if you're functioning or you're still in the mindset of someone's PCP, where you're trying to coordinate all their care. You're trying to make sure that they're doing this, that, and that. Really, in this risk adjustment space, you're really having to capture what counts. And though it has potential to be very good, and it does have potential to improve health outcomes, it's a numbers game. And there are things that you really don't have time to touch, but internally, like, I really need to be able to address this, but you really can't, in order to be able to continue getting the results for the program. So I'm trying to be vague, but also try to kind of explain it. A lot of it is heavily how you chart, how you bill. And I'm still a person who, I've been a nurse practitioner working in this space for over 10 years. And I still, every year CMS comes out with new policies and things like that. And so I can honestly say I'm not an expert, but it even took me a while, because I came into this space after being working in a family practice office where I was a lot of people's PCPs, and I was used to, okay, I'm going to do this, I'm going to order this, I'm going to prescribe this, and I'm going to have this person come back in 3 months. Where in this space you may see this person once, maybe twice a year, and you're trying to make sure that you're closing gaps of care. So if a person has diabetes and they don't have an A1C on file that has been within the last 3 months, doing that. But then again, you may see that this same patient with diabetes has needs, diabetic shoes, which you can write for that, but you're not their primary care team. You're ancillary almost. And I find it hard for people to put themselves in the role where you're not the main driver of the care, if that makes sense. So hopefully that wasn't a ramble. Hopefully that makes sense to you guys. And let's hop on over to this article, with the hope that it will explain a little bit more. So this article by Medical Advantage, it's simply put, what's the difference between value-based care and fee-for-service? And so their definition of the value-based model, it says it rewards healthcare providers who focus on the quality of provided care. Reimbursement of services is based on those providers' effectiveness in preventing illness and promoting health. So at a high level, this is great, right? Isn't this what we want to do? And again, if I scroll up here, it says here, in 2010, when the Affordable Care Act came out, when we were talking about the Affordable Care Act, it codified reimbursement for value or quality instead of fee for service or quantity of care. Value-based care was already emphasized by CMS for the 2 years prior. So really, when that Affordable Care Act came in, it was more so about giving better quality than just seeing a whole bunch of patients and then seeing them for, maybe there was a service that you could render, for, I don't know, maybe a patient came in with COPD and you gave them a nebulizer treatment. Well, that's fee for service, you know what I'm saying? Whereas with value-based care, you have a patient with COPD, and yes, you can give them a nebulizer treatment, and you can, definitely bill for that. But where you get rewarded in this system is making sure that they're going to a pulmonologist, that they've been referred to a pulmonologist, that they're on the medications that the guidelines say that they're on, and that you're charting this, because if it's not charted, we don't know. It's as if it does not happen. We all know that. So it's quality over quantity, okay, at a high level view. And it is focused on providing care that is effective, applied judiciously, and documented accurately. And that, my friends, is a doozy within itself. There are so many codes. Like, I think of diabetes, and there are so many different codes and umbrella codes, but there are some codes that are more prioritized than others. That's where a lot of people kind of get a little hairy. I was always told that, for one, you never want to do a diagnosis or a code that has unspecified. It needs to be specified. Okay. So for instance, it's never CHF unspecified. It is chronic chronic systolic heart failure. You want to be as specific as possible. I remember working at an organization where they didn't want us to do diabetes mellitus type 2, and then another diagnosis would be polyneuropathy. They wanted us to always link it back to diabetes. And that was very hard for people to really wrap their minds around, because they were like, what if the neuropathy wasn't caused by diabetes? And what was told to us is, if you can't prove it, i.e. there's no documentation, like the patient neuropathy came when they were 20 years old and they were in a bad car accident and they have back pain and all this stuff like that. If you don't have documentation like that, then it automatically needs to be linked to diabetes, because we know that that is a complication. Now, they went on to explain this a little bit more, but everybody was like, but what if, when we're only seeing people once or twice a year, how can we say for sure? And it was a big conversation. So let's go and look a little bit further. Right here, it says the shift to value-based care is expected to continue as CMS continues to hand down new policies that encourage and incentivize care quality over quantity encounters. You see that there? And I want to say this year, they put out even more. With us coming out of COVID, there was a lot of guardrails. It was a little, I don't want to use the word lenient, but there was a little bit more openness of like what you could bill for, because so many people had to see people virtually. Well, come May 2023, all that telehealth for COVID went away. And there were new guidelines that came in there. So a lot of people now, telehealth is not being reimbursed like it was a year or 2 years ago. And so this article goes in and talks about the different types of value-based care. I have typically been a part of shared savings and shared risk. Typically the shared risk, which is this model, also known as the downside risk model, allows providers to share savings but not risk, because the provider is accountable to the AACO. Benefits of a shared risk model include an increased potential for profit. However, the risks increase since providers must cover a portion of all the extra costs above target rates. So then we talk about the fee-for-service. The fee-for-service model pays healthcare providers based on the individual care services provided without regard to effectiveness of that care upon payment. Now, if you've been working for a bit of time, you might remember or if you've been a patient, where you would get the explanation of benefits and you would see like they've charged you for venipuncture, and they did a culture swab on you, and they did your pap smear, and they did all this other stuff. That is, and mind you, they could have billed for all of that. Okay. They really could bill your insurance for all of that. If that's what they did, that was a billable task, right? But what I have found, and even as a patient, I have even been on the end of where I'll look at my explanation of benefits and I'm like, this person, like, it's like everything they could have done for me, they did. And what I was victim of, and I don't know if some of you have, and I hope as providers you've not done this, but you'll see, I have felt like my insurance was taken advantage of, because they would see what kind of insurance I had, and they would know that that insurance will pay for this and they would pay for that. And they would just do everything for me. Not that it was warranted. It was a like to have, or we could do this, this, and this, but none of that stuff necessarily had to happen for them to figure out what was going on with me. Okay. I know for a fact, I have gone to some dentists that have done that to me. I would go in for just having my teeth clean, and they would try to do any and everything under the sun and bill for all those tasks. And that's why this model was created. That's why I see on the high side, on the good side, why this is a value-based care, because what was happening is people were billing for all this stuff, but patients weren't getting better. So yeah, you're billing for all these tasks, and insurances are paying for all this, but the patients are still in the same predicament that they were in when you saw them. They're no better. Where with value-based care, you get rewarded for your patients getting better and having healthier patients, right? So I most definitely will tell you to read through this, and they give 5 key differences and benefits between the two. For anyone still wondering what value-based care would do for your practice, these are the clear benefits. Okay, so policy shifts offer advantages. Um, it states that CMS continues to update the policy that encourages value-based care. Private payers also shift to contracts for account for quality. Practices and providers already prepared to offer value-based services will have an advantage over those still focused on a fee for service. So you get rewarded for giving better quality, and in essence, quote unquote, having healthier patients. There's penalty protection. There's better long-term health outcomes because, again, if you're focusing on quality, the assumption is that you're going to have better healthcare outcomes. The patient engagement is going to be better because instead of a patient coming in and saying, well, I got all this stuff. I've had tons of patients. I've heard patients say this a lot. Well, like, when I go into the doctor, they only want to talk about the one thing, but I had all this other stuff. Well, supposedly you're supposed to be able to offer more patient-centered care, whole person care. So you're looking at the patient as a whole to be able to give them more value-based care. So the patient engagement will go up because they'll be more satisfied. And then you get better insights. It says that this care requires paying closer attention to the trends, the data, governing your practice and patients. You'll learn more about your practice, likely in surprising, helpful ways. So what I task you to do is look this up and read through it, okay? And I have found that there are a lot of jobs, there is a lot of shift. A lot of organizations are at least launching some type of model of this. And yeah, and so what are my thoughts about this? I think in theory, this is a good model to have. What I have found, though, is that it is heavily based on documentation. It's heavily based on certain codes. And there are sometimes in an effort to be able just to get to complete visits, you have to overlook certain things because when it comes to more acute conditions like, I don't know, allergic rhinitis, that counts for little to nothing, right? That's nothing. But you spend more focus on you are more focused on your chronic diseases like diabetes, and I get it. But what I have kind of seen is that I have had a lot of patients that will tell me, well, my doctor takes care of me. You know, my doctor makes sure that I have all this stuff. Why do I have to talk to you? And they don't know that their insurance, their Medicare plan has opted them into this program. And it just feels like it's not full transparency. And it can kind of feel at times like we're just kind of taking advantage of what's just being offered. But it's legal. And it's not like, it's not like we're lying to them, but it's like, it seems excessive. I'll say that. It can seem excessive, especially for the patient who goes to their doctors regularly. They have good doctors who are crossing their T's and dotting their I's. And here I am coming in with a program that maybe one of their specialists opted in for, their PCP opted in for, or, a lot of insurance companies, Medicare Advantage plans have opted in for, and here we are, and it's like people are like, I just don't see a need for this. And I really don't have a rebuttal for it, especially more so for the person who is on top of their care. And that's just my opinion. I I make the most. I have made the most out of it because, again, yes, I know I have to capture certain things, but I also take care of other things as well. So I make sure that I'm giving the quality. The great thing about this as a healthcare provider is you have very low, what is the word? Liability. You have very low liability. So if you miss something, I mean, the buck doesn't stop with you, and so, you really can focus on quality. And that's where I have been able to find a lot of like work-life balance is that like I'm not up late at night charting. I'm not working after hours. The visits I do, there's not a lot of follow-up with the patients. You do only see patients about once or twice a year. It's not a wellness visit. It's not an annual that you're doing with a lot of people, but you're making sure that you're capturing everything about the patient. So then other things can be fired. There's other triggers that come off of, being seen by someone like me. So I don't know. Drop down in the description box and let me know what you all think. If you have worked in one of these models, like how do you see it? And, where do you feel like we can improve? Because I think at the high level, it is something that is very beneficial. And this is what people do want. I just think that sometimes the structure can still tie your hands. So that is our hot topic. So going into our last segment, we are going to go into the diabetes corner. And today, what I want to focus on is talking about our eyes, our eyesight. And so if you don't know, August is a couple of eye awareness months. So like the first one that it's National Eye Exam Month. And then it's also Children's Eye Health and Safety Month. So let me go ahead and share the National Eye Exam portion. And again, I will link these for you all. So this is August is National Eye Exam Month. And one of the complications of diabetes is retinopathy. And so for the provider that is out there, for the patient that is out there, you want to take care of your eyes. People who have diabetes are more likely to develop cataracts, to develop glaucoma, to develop blindness. Okay. And so what I like to do is one of the questions that I ask all of my patients that have diabetes is when was the last time that you had your eyes checked? And not only that, the last time they've been dilated. Okay. You need to have a diabetic retinal exam at minimum yearly. I have seen a lot of ophthalmologists have their patients come in every 6 months. It just depends on what they see. I've had some people where their eyes were good and they only had to come in yearly. But I've seen a ton of people who they have to come in twice a year, even some every 3 to 4 months. So definitely want to talk about this. And this just gives like a National Eye Exam Month timeline. I thought it was kind of cute, but it was given just some pointers of like, how can you observe this month? So of course, take the exam and encourage others to do that and to make sure that you have the right prescription. Be very honest for those who are patients. Be very honest with your doctors what you see. You want to make sure that they get your prescription right. So definitely wanted to touch on that. But then I also wanted to speak on something else, especially because last week I spoke about back to school tips for children and kids with diabetes. And I wanted to share this. I thought this was very timely because, and here, let me share this with you all. Here we go. So health.gov has their national health observances. So for anyone who doesn't know, every month has some type of observance, but also a health observance as well. And so in the month of August, here are the ones that health.gov recognizes. Now there's other ones that are out there. You can do a Google search and find a whole bunch of them. This one is National It's States, it's National Breastfeeding Month. Black Breastfeeding Week is in the month. It's National Immunization Awareness Month, and then Children's Eye Health and Safety Month. And so it really wants to highlight the importance of protecting children's vision and their eye health, and giving them some resources that that you can talk to kids about. So let me share another resource with you all. And again, we'll link these for you. Look at those cuties. Look at them. And so one of the reasons why I wanted to share this is because, like I said, last week I talked about like back to school tips, back to school diabetes tips. So if we're talking about children, of course, we need to talk about their eye health as well. I was actually thinking it's funny because even this month, my kids are going to go get their annual eye exams. And I already have one that's in glasses, and I have my second one I think is going to need glasses as well. But this, I feel like, definitely for children who have diabetes, and typically, not all, but typically what we find in children, school-age children, typically is type 1. We are seeing an increase in those that have type 2, but one of the things that you definitely want to consider is, just for one, it's just regular preventative screening. Every child should get their eyes checked at least, like they need to get their eyes checked annually. When it comes to the complications from their diabetes diagnosis, typically with type 1, they'll have you wait a few years before they start doing the more focused eye exams, because it takes some time for complications to really rear its ugly head. So for a patient that has type 2 diabetes, you want to go ahead and start getting them into the different specialists quickly, because with type 2 diabetes, it's probably been festering undetected for years. They've even said up to a decade. So by the time we're actually able to detect diabetes, the complications have been working in the system for a while, where with type 1, which is more of a quick onset, they may hold off for 3 to 5 years. And it really depends on what they see, how old the child is, all of that. But in general, children should be having their eyes screened. And so I wanted to share this resource with everyone, but also just talk about this and bring this to light as well. And so I want to also mention that as we have started to come out of this COVID era, we have found that more patients, more children are having more eye issues. Why? Because they're on electronics more. They were doing, I know for me, my kids did online school. So they're looking at a computer screen, just like I'm looking at a computer screen working from home. They have tablets. They're looking at TV more. They're playing games online more. And so that all affects our eyes. Here it says, here are some warning signs of vision issues. It may be hard that would help you be able to spot if there's some issues. If there's some eye rubbing, closing one eye to read or watch television, excessive tearing, light sensitivity, and wandering eyes. I would even like to add to this squinting. That's what I found. That was when I was a child, that was what alerted my teacher, who then said something to my mother. I actually think the teacher said something to the school nurse, who then checked my vision, and then she told my mother. And that's how I figured something was wrong with my own children, is because they started doing this squinting thing. Let me see if I can show this to you. They started doing this when they were looking at stuff. That was what they were doing. And I find that that's what a lot of people, how it presents for everybody, but it may not. And so wanted to definitely share that article with you guys, and to remember to make sure that the children are getting their eyes screened, because this is National Eye Exam Month, as well as National Children's Eye Health Month. And so wanted to definitely share that with you guys as well. Okay, guys, that's all I have. Don't have anything else more. If you have not already, please subscribe to my YouTube channel here at Kim E, the Diabetes NP. If you're watching on YouTube, if you're watching on LinkedIn, go ahead and give me a follow, or if you are watching on Facebook, go ahead and follow me over there as well. I'm Kim E, the Diabetes NP, or the Diabetes NP everywhere that you can find me on one of the two. And so I would definitely love to hold you here with me and be a part of my community. And for those who've been rocking and rolling with me all this time, I want to say thank you. Okay. We've been doing this for 4 years and I appreciate you all so much. And so I would like to also ask you guys, is there any hot topics that you want me to address and give a little commentary over? I don't know everything. And I'm not going to be that person you will never see me present myself as a person who knows everything, but what I know, I know. And I can always form an opinion about anything. And so I want to open it up to you all. If you want to suggest any hot topics or any topics that you want me to cover in the hot topic segment or the diabetes corner segment, I'm open. I'll review them and I'll see what I can do. You have been sitting here with Kim E, the Diabetes NP, and I will catch you next week. Bye.